Hi, today on Student Nurses Success, we're going to continue our respiratory series. This particular map is going to cover the most common respiratory infections. Now, a lot of respiratory infections are in children as well. We do have a separate map on pediatric conditions, but this map is going to just cover common respiratory infections that can affect both children and adults. Let's go ahead and get started with our blank map. Remember, you can find the link to the maps in the comment section. We're going to start with viral rhinitis. Viral rhinitis is really just the common cold. It can be caused by a lot of different viruses, rhinovirus, parainfluenza, adenoviruses, even RSV. Even COVID can cause an upper respiratory infection. So, in this particular disorder, we're really just talking about upper respiratory infections that are causing a lot of nasal discharge, headache, fever, maybe malaise, congestion, cough, watery eyes. And for the most part, just viral rhinitis is just a very general term. And you would actually maybe diagnose a specific viral agent as the cause, and then you would call it you have RSV or you have parainfluenza. But if you're not testing for it and you're just getting a runny nose and not feeling well and feel like you have a cold, we just refer to that as viral rhinitis. It is, for the most part, self-limiting. It kind of runs its course, and you don't really need any follow-up with it. Maybe some antibiotics if you go into some type of secondary bacterial infection. Now, rhinosinusitis is swelling and inflammation of the actual sinuses. And often, rhinosinusitis occurs after um, a cold or upper respiratory infection. So, some individuals have a lot of problems kind of getting over these colds. They kind of move into a bacterial infection, or sometimes the virus can really hang on there. For acute rhinosinusitis, it really is less than 4 weeks. It may resolve on its own if it's viral. A lot of times it can be a mixture of bacteria and viruses. And if you're getting a lot of green nasal drainage and you're really just not getting over it, a lot of times there's some type of bacterial infection that is kind of set in secondary. Some individuals have chronic rhinosinusitis, which is a lot more difficult to manage. They may be prone to it, and chronic is when it's gone on for several months. In those cases, the bacteria may actually be anaerobic and need a very specific antibiotic in order to treat that. Let's move over to influenza. Flu season is usually the winter months. It's highly contagious. Flu usually causes, isolated epidemics. We usually have issues with it throughout anywhere from maybe October through March of the year. Flu is transmitted by droplet. Incubation is anywhere from about 1 to 4 days. So after you've been exposed, you can be at risk for developing it within a few days. Now, people generally are infectious about a day prior to having kind of full-blown symptoms. So that's problematic because that's hard to stop an outbreak then because you may not even know that you are sick. There are different subtypes of influenza. Type A is probably the more difficult subtype because it includes the H, which mutates very frequently. And so that's an issue that we may have a flu shot all set up to maybe cover what we think is going to be the specific subtype of type A that's out there this season, but that H subtype mutates and changes, and then people may not be as covered by their flu shot. Although the flu shot does help maybe make the disease course a little less severe, a little more limited. So it is always helpful to get your yearly flu shot. Other types include B and C. Manifestations of flu are fever, malaise, a lot of achy, a lot of muscle aches, maybe headache, cough, sore throat. The thing about flu is it tends to rapidly onset. It doesn't like develop over the course of a day or two. It tends to kind of hit you pretty quick. Within a few hours, you know you're feeling pretty ill. Again, you don't have to have all of those symptoms. Those are the range of symptoms that you can have. Complications of flu, if it hangs on, can develop into a sinusitis or a sinus bacterial infection, bronchitis, pneumonia, otitis media, and that stands for ear infection. Especially in children, we see it develop into ear infections. So the complications of flu are really kind of as bad as the flu itself. So that's why it's super important to prevent flu. And our best prevention is the yearly vaccine, which they kind of reformulate every year in predicting what type of flu and subtype is maybe going to hit us the hardest. They look at other parts of the world and they can kind of see what's heading our way. For flu, if you catch it within a short time period, an antiviral might be helpful in limiting signs and symptoms. And antibiotics are really only helpful for the flu if there is a bacterial complication or a secondary complication, such as these that we've talked about above. Let's move on since we kind of started talking about pneumonia a little bit as a complication of flu. Let's go ahead and talk about pneumonia. I'm not going to give us all our information here. Let's just kind of stop here to begin with so that we don't overload you with too much information to start. So the real thing with pneumonia, really what it is, or the definition, is inflammation of the bronchioles, the alveoli, and the interstitial tissues. So pneumonia is a lower respiratory infection. Causes of pneumonia can be viral, can be bacterial, fungal. Inhaled irritants can kind of exacerbate and cause pneumonias as well. Really, what we see most common in the public is either viral pneumonia or bacterial pneumonia. And they actually present very differently. And we'll kind of talk about the way that each of those presents. High-risk individuals for pneumonia is our older adults, our older population, those with a diminished gag reflex. And we talk about people who maybe have neuromuscular disorders where they really may have a decreased gag reflex that predisposes them to aspiration and aspiration pneumonia when you actually kind of get some of that stomach acid and aspirate that into your lungs that can kind of harm those lungs, change that situation in the lungs, and lead you open to the development of pneumonia. We know that our patients who are hypoxic, maybe those with COPD or chronic lung disorders, are at increased risk of pneumonia as well, the immunocompromised and the seriously ill. Now, there are two types of pneumonia that we kind of categorize into community acquired or hospital acquired. If you have community acquired pneumonia, that means that you develop pneumonia outside of the hospital situation. If you are admitted to the hospital and you develop pneumonia in less than 48 hours, then we are saying that that is community acquired. You obtained or caught that pneumonia or caught that bacteria out in the community setting. So it's community acquired is outside of the hospital or less than 48 hours in the hospital. The reason this is important is because we treat these differently. So these are treated differently. And let me talk about hospital acquired, and then we'll talk about why and they're treated differently, because I think it'll become pretty obvious here. With hospital acquired pneumonia, again, this is not present at admission. It is something that you developed in the hospital. So the pathogens in the hospital te- tend to be more resistant to antibiotics. They tend to be a little bit stronger, bacterias and pathogens. And so they require different types of antibiotics than community acquired. And it's just really related to the resistance of the pathogens that have been in the hospital setting. Because we do a lot of cleaning agents in the hospital and people in the hospital are very, very sick. The pathogens that you catch in the hospital tend to be more difficult to treat than the ones that you catch out in the community. So we do see a higher mortality rate with hospital acquired. Now, the patho behind pneumonia is really the microbes enter the lung, and when they enter the lung, those pathogens trigger this inflammation. And remember, pneumonia is inflammation of the bronchioles. And then what happens with this inflammatory response is the alveoli start to fill with fluid and they will fill with fluid if this is a bacterial pneumonia. And that's going to be a problem because if you have fluid inside your alveoli, it's actually going to impair the oxygen diffusion. So you have your little alveoli, and if they're filled with fluid like this, then gas cannot exchange on all these surfaces. And so it really decreases gas exchange and it really is going to impair oxygenation in patients. Manifestations of pneumonia, again, we have a range: fever, cough, sputum production, difficulty breathing, coarse breath sounds, or even diminished breath sounds. Now, if those alveoli are filled with fluid, then gas is not exchanging in that area. And so you actually have decreased breath sounds in the area where the pneumonia is lying. And so, depending on what lobe, pneumonia tends to settle in our lower lobes, so that tends to be where breath sounds are diminished, but that's not always the case. You can have pneumonia in a different lobe. When we x-ray someone with pneumonia, we are actually going to see something called consolidation, which is white areas in a patient who has pneumonia. Again, remember, your lungs should be filled with air, but when they're not filled with air and they're filled with fluid, they show up dense or white on the x-ray, and we call that consolidation. If you look at an x-ray, you notice that your ribs show up white because they're very dense, they're bones. And so any white that shows up in the lung fields is actually probably going to be fluid and indicate that the patient has pneumonia or some type of inflammation that is causing fluid buildup. Now, this is primarily how bacterial pneumonia runs. And remember, I talked about generally viral or bacterial, the most common. Viral pneumonia we call atypical pneumonia. And actually, bacterial pneumonia we call typical pneumonia. But viral atypical pneumonia, it acts a little differently. We generally do not see as much of a productive, or we see a cough, but it tends to be non-productive. We tend to see a normal white cell count because it's not bacteria related. We generally do not see much change on the x-ray, so we don't see that consolidation, and the fevers tend to not be as high. And viruses we cannot treat with antibiotics, and so viral pneumonia or atypical pneumonia just sort of has to run its course. So we kind of call it self-limited. Now, that doesn't mean that a viral pneumonia cannot turn into a bacterial pneumonia, worsen, and then require antibiotic treatment there. Let's move over to tuberculosis. And let's just kind of go down a little bit so we don't overwhelm you with too much information here. So tuberculosis is a bacteria. So this is the etiology is bacterial, and the specific bacteria is Mycobacterium tuberculosis. Again, our high-risk patients for developing tuberculosis would be those who are immunocompromised, maybe the elderly, some who are maybe malnourished and not as healthy. But these other two high-risk situations, overcrowded conditions, maybe people living in a lot of close quarters, prisons, maybe high risk, and some immigrant populations. And those specifically are probably newer immigrants, maybe. coming from countries who do not have as good of access to health care, or perhaps newer immigrants who have not really moved into our healthcare system and may have come with this bacteria on board. Transmission of tuberculosis is airborne or a droplet. Mycobacterium is very, very tiny, and so they tend to float in the air very easily. And so we use those N95 masks to kind of help with that. And we use reverse isolation rooms if we know someone has an active case of tuberculosis, because that bacteria kind of floats in the air and suspends in the air for a little bit of a period of time. As far as the patho, tuberculosis primarily infects the lungs, but the lungs and the lymph system, but it can infect other organs, although that is not as common. We primarily see it settling into the lungs. There are two phases, stages of tuberculosis, and this is why it becomes kind of a difficult bacteria to get under control in some conditions. The primary or latent stage is that when you inhale the mycobacterium, you may not develop symptoms for years. And what happens is in someone who has a nice, healthy immune system, when they inhale mycobacterium, what will happen is the body's immune system will actually wall it off and will actually encapsulate it and keep it from spreading. And that's really helpful because you won't get the symptoms of tuberculosis. And it can lie dormant for years and years and years. Our T cell mediated immunity does that. Now, this little walled off area will become kind of calcified and fibrotic. However, if it's a tiny area in your lungs, it's not going to be a huge ordeal for you. But eventually, at some point in time, that walled off area is going to break loose. And it happens at a time where maybe your immune system becomes impaired. Maybe you develop cancer and have to undergo treatment. Maybe you are immunocompromised from taking steroids, or maybe you just get very, very ill and become immunocompromised. At that point, it can reactivate. And when it reactivates, it breaks loose, it starts to spread, and it gives you acute symptoms or acute manifestations. So at this point, it becomes what we call active TB. Active TB is the TB that can spread from person to person. So if you're living in close quarters and you're coughing, that's those little those little tiny mycobacterium are floating in the air and other people are getting it. So let's talk about the manifestations. Again, in primary, you probably have no symptoms. You don't even know you have it. So you're kind of carrying around this bacteria. You're not sick from it. You're not spreading it, but at some point you probably will, but we don't know when that is. So that would be the best time for us to identify it. You have it, you don't have symptoms from it, you're not spreading it, and we can identify it and eradicate it if we can screen you for it. Now, once you start to get into progressive TB, you're having fever, night sweats, cough, fatigue, weight loss. You are actively sick and spreading it. Now, how you diagnose it is if you're coughing and actively spreading it, we can grab a sputum and isolate it out of there. We can perhaps see it on a chest x-ray. Maybe we can see an area that looks suspicious for TB. Um, and we can also even draw a lab test and see that you have the TB antibodies, and if you're having active symptoms, then perhaps you have active TB. If you are in the primary stage and you do not have active TB, we can still identify it. We can do a PPD skin test where we put a little bit of the TB antigen under your skin, have you come back 48, 72 hours later, and we can see if you get a reaction to it. If you have a reaction to it, then we can investigate further and see if you have some of these nodules kind of walled off in your chest x-ray, in your lungs that show up on your chest x-ray, and then we can treat you and eradicate it and get rid of it. We can also draw this test called a quantiferin gold test, which measures the T cell mediated activity from TB. So that's why healthcare workers, we check yearly for TB or on a regular basis, because you may have been more exposed to it because people with active TB tend to go to the hospital. So we do like to kind of screen children, we screen healthcare workers. Maybe if you're new to the country, we might screen you. If you're living in crowded conditions, we may screen you so that we can get a handle on it so we don't have a TB outbreak. So, prevention is really frequent screening to identify cases. There is a vaccine called a BCG vaccine. It's not terribly effective. It does help some, and we know that some individuals in other countries actually may have had the BCG vaccine. And if you have had the BCG vaccine in your lifetime, then our screening tests are actually not going to work to identify. Um, if you've been exposed, because you have been exposed, because you've been given a vaccine that gave you and you made some antibodies. So we have to kind of look at different tests to screen you if you've had the BCG vaccine. Treatment would be multiple antibiotics over extended period of time. Treatment's usually several weeks. And this is due to resistance because it takes so long to treat it. A lot of people kind of fall off the path of goodness and don't finish their antibiotics. So we have developed a lot of resistant strains over the years. So we're looking at multiple antibiotics over an extended period of time in order to eradicate and treat this. All right, let's move on down to our last infection we're going to cover, and that is COVID-19. Again, we're only going to pull this down a little bit so that we don't overwhelm you with information here. A lot of people are familiar with COVID-19. It is the etiology is it is a virus and it is the SARS-CoV-2 virus. We know that COVID-19 is highly contagious. It caused the pandemic in 2020. We know it's the seventh coronavirus to cross over to the human species from animals. So these are newer viruses to us. Adenoviruses are everywhere. We have lots of them, but the coronaviruses in the humans is a newer virus, and there's not as many of them out there. Doesn't mean we're not going to get them because they seem to be mutating quickly. It causes severe acute respiratory syndrome, although COVID-19 we know can affect other organs as well. With the patho, the virus has these spike proteins. I'm sure you've all seen the picture of the little COVID virus, and these that I'm drawing are the little spike proteins. And these little spike proteins are really good at attaching, and so they will attach onto your host cell. And this is the host here. And so that's why they work so well. So this virus binds to the host cell and it binds to ACE2 receptors in the epithelial cells that are in our lungs, kidneys, brain, blood vessels, and our intestines. And that's why we get some of these other symptoms with COVID-19. A lot of people can have maybe diarrhea, or they can have intestinal symptoms with COVID-19. With blood vessels, we've seen the development of clots and vasculitis with COVID-19. Brain, we've seen brain fog, kidneys, and, lungs, obviously, a lot of coughing. Now, patients who have increased ACE2 expression are going to probably be more affected by COVID-19. And those with diabetes and hypertension, we know, have increased ACE2 expression. And so that's why those individuals seem to be a little bit higher risk for developing COVID-19. COVID-19 is an RNA virus. It hijacks the host cells. It uses its little crown spikes to attach to the host cells, like I drew the picture here. And what happens is once it gets into those host cells, it produces what we refer to as an exuberant inflammatory response. So a big old inflammatory response and just causes uncontrolled inflammation. And that's where we get most of our symptoms from. Transmission is from droplet, tiny particles, and contact with secretions, including fecal contact. So it's spread in multiple ways. Manifestations, again, you can have a range of these and they can range in severity. Fever, you can have fatigue, cough, shortness of breath. Those are our lung symptoms. You can have this diarrhea. Those are our intestinal symptoms. Loss of taste and smell. That's a very unusual one that is associated with COVID-19 infection. Sore throat and cold and flu-like symptoms. So your typical symptoms there. Our bigger problem with COVID-19, it's bad enough that you have COVID-19, but we do see the development of complications similar to the types of complications we see in influenza. Pneumonias can develop, but in addition, we can see these blood clots, which can cause stroke. Individuals have had stroke post-COVID, organ damage to your heart, lungs, and kidney, mood changes because it affects your brain as well. So lots of other complications beyond the typical bacterial infections that we see in influenza. Now, there's a couple long-term complications that are very unique to COVID. One is MIS or multi-system inflammatory syndrome that can develop about 6 weeks after a COVID infection. And the people who develop MIS, they may have had a documented COVID infection, they may have had a mild COVID infection, or they may have been asymptomatic for COVID. But what we see is about 6 weeks later, we get this inflammatory flare up, and it involves multiple systems. Your heart, it can affect your kidneys, your lungs. And so a lot of those patients get very, very sick and end up in the hospital, a lot of supportive care. Some completely recover, some may go on to develop post-COVID syndromes. Now, people who develop post-COVID syndromes don't necessarily have or had MIS. Some individuals, the COVID just hangs on and just kind of low level lurks and causes these post-COVID syndromes of ongoing fatigue, weakness, brain fog, achiness, headaches, even heart problems. And this is going on for months to even years in some individuals. We're not really sure how to treat all of these. We're kind of working through symptomatic treatment as we learn more and more about COVID-19 and its complications. So the best thing of all is to go ahead and try to prevent. And there are vaccines out there. Those vaccines, they are kind of getting into that routine like they do with flu shots in kind of adapting those vaccines based on the latest mutations of COVID. There's many different mutations of the original COVID-19. Those vaccines use a piece of messenger RNA to send a message to the body, and the piece that they send is actually from the spike protein. Um, and that's how they're kind of formulating these. Now, these mRNA vaccines, this technology, although it seems to be newer to a lot of us, it's actually been around for a while. They've been using mRNA technology to develop cancer vaccines over the last 20 some odd years. And so when COVID-19 hit, they did a switcheroo and use that technology to develop the COVID vaccine very quickly to be able to get it out to the public. Other prevention is monoclonal antibodies that if you're exposed to it, we may be able to give you some short-term antibodies to help reduce infection, but you would not keep that immunity if it's an antibody that we give you in the short term. It would just be in the short term to prevent that particular infection or exposure. Treatment, there's some oral medications. Again, we need to start those pretty early, just like with influenza. In fact, influenza, we start those antivirals sooner than 5 days. But with COVID, we're going to try to treat those and start those antivirals within a few days of symptoms. Steroids to help reduce that inflammatory response has been helpful. Biologic agents, antibodies we've been using to give, and just supportive care as well. So we're kind of working through treatment. We're mostly just treating symptoms and complications because it is a virus, and so we don't have a ton of antivirals available for it yet. There you go. There's a pretty good overview of probably the five biggest or most common respiratory infections. Make sure to subscribe and like to our channel so that you're up to date and getting all our new videos. And continue in our respiratory series where we will cover pediatric conditions and chronic conditions and some other respiratory conditions.